Michael flew in on a Tuesday because his sister said their mother sounded off on the phone, and off turned out to be an understatement. Barbara met him at the door, already mid-argument with someone who wasn't there, accused him of moving her reading glasses when they were sitting in her own hand, and asked him 3 times in 20 minutes what day it was, each time as though she'd never asked before. She seemed physically fine, steady on her feet, no fever that he could tell just by looking at her, which somehow made it more unsettling rather than less. This wasn't a woman who'd taken a fall or come down with something obvious. This was his mother's mind, seemingly overnight, behaving like a stranger's. Michael had spent 2 years quietly bracing for this exact moment, the one where his mother's mind started slipping, and standing in her kitchen that afternoon, he was almost certain it had finally arrived. It hadn't. Or rather, it had, but not the way he thought, and not permanently. I'm Dr. Walter Hale, nearly 4 decades of practicing medicine, and tonight I want to tell you about a single habit, not a list of 7, not a countdown, because this one deserves the room a full story gives it. It's not really a physical habit at all, if I'm being fully honest with you. It's a habit of staying quiet, of treating something as too embarrassing or too minor to bring up, and that silence is doing more damage in my patients over 60 than almost anything else I see that would otherwise be simple to fix. Before I tell you what it is, I want you to think back honestly. Has a parent, a spouse, or you yourself ever noticed a change in bathroom habits, needing to go more, needing to go suddenly, waking up more at night for it, the occasional accident, and simply decided it wasn't worth mentioning at the next appointment? Tell me honestly in the comments. I'd guess almost everyone watching this has a version of that story, and most of you have never said it out loud to a doctor, not because you forgot, but because some quiet part of you decided it wasn't worth the discomfort of bringing up. Here's why I need you to say it out loud from now on, and Barbara's story is exactly why. Barbara and Michael are a composite, drawn from a number of similar situations I've watched unfold over the years rather than one specific family, so there's no privacy concern in walking through it in this much detail. But the shape of it, right down to the reading glasses already in her hand, is drawn from real cases I think about often. When Michael called me in a panic that evening, genuinely convinced his mother's dementia had suddenly accelerated overnight, I asked him a question that probably sounded strange given what he'd just described. I asked whether his mother had mentioned anything about using the bathroom more than usual lately, or whether she'd seemed uncomfortable, or whether there'd been any accidents she might have brushed off. He didn't know. Nobody had asked her, and she certainly hadn't volunteered it. She had, in fact, been quietly dealing with several weeks of urinary symptoms she found mortifying to discuss with anyone, including her own children, and had said nothing. What Michael walked into that Tuesday wasn't dementia arriving all at once. It was a urinary tract infection, and in older adults, that specific kind of infection does something that surprises almost everyone the first time they learn it. It frequently skips the symptoms you'd expect entirely, the burning, the urgency, the discomfort that would send a younger person straight to urgent care, and shows up instead as sudden confusion, disorientation, agitation, or a personality that suddenly seems wrong. Doctors are trained to specifically check for a urinary infection first, every time, before assuming a sudden mental change is dementia progressing, precisely because this pattern is common enough to have a name in geriatric medicine, and precisely because it's this reversible. It's worth understanding briefly why age changes the picture so dramatically, because it isn't random. A younger person's body responds to a bladder infection with a very deliberate, localized alarm, inflammation right where the infection is, which reliably produces that burning, urgent, unmistakable discomfort. Several things shift with age that blunt that alarm system specifically. Nerve sensitivity in the bladder and urinary tract can decline somewhat over the decades, meaning the same infection produces a quieter local signal than it once would have. At the same time, an aging immune system tends to respond to infection more through generalized inflammation that reaches the brain and disrupts normal brain chemistry and alertness, rather than mounting the same sharp, localized response a younger immune system would. The result is that the infection announces itself through the brain instead of through the bladder, which is the exact opposite of what everyone, patients, and many caregivers alike instinctively expects. And it's why doctors are taught to check the bladder first when an older patient's mind changes suddenly, rather than gradually. We treated Barbara's infection with a standard course of antibiotics. Within 4 days, she was arguing with Michael about something considerably more mundane, whether he was staying long enough for his visit, which, as he told me afterward with real relief in his voice, was the most normal conversation they'd had in a year. Urinary tract infections are already one of the single most common infections seen in older adults generally, common enough that most family doctors treat several every single week without a second thought. What's underappreciated, even among some families going through it firsthand, is how disorienting the confusion version can look from the outside, and how quickly it can be mistaken for a permanent turn rather than a temporary, treatable one. I've had adult children apologize to me afterward for how certain they'd been that their parent was gone, using almost that exact word, only to watch that same parent return to themselves within days, once the actual cause was identified and treated. I want to be careful here because I don't want a single person watching this to walk away thinking every case of confusion in an older adult is simply a hidden infection. It isn't, and real cognitive decline is real and deserves its own careful, honest evaluation. But a urinary tract infection is one of the most common, most fixable, most frequently overlooked explanations for a sudden change in someone older, and it gets missed specifically because nobody thought to ask about bathroom habits, because bathroom habits are exactly the thing everyone, patients and families both, treats as too embarrassing or too unimportant to bring up. Barbara's case is what pulled me into this topic. But the silence around bathroom changes causes real problems even when confusion never enters the picture at all. And I want to walk through those too, because this affects both men and women in different ways for different underlying reasons. For a lot of women watching this, the pattern is what's called stress incontinence, a small leak with a cough, a laugh, a sneeze, or picking up something heavier than expected, caused by pelvic floor muscles that have weakened over the years, often going back to childbirth decades earlier, then continuing to loosen further with age and with the hormonal changes that come after menopause. It is extremely common, far more common than most people assume, and it is also one of the most treatable things I see, because pelvic floor exercises, done correctly and consistently, meaningfully improve it for a large share of the women who actually stick with them. I want to be specific about what that looks like in practice, because most people who've heard the term have never been shown properly. Done correctly, it means identifying the exact muscles that stop the flow of urine midstream, then contracting and holding them, not the muscles in your stomach, thighs, or backside, which is the mistake that makes so many people give up, convinced it isn't doing anything. A real pelvic floor physical therapist can confirm you're engaging the right muscles, often within a single visit, which is exactly why I mentioned that specific referral rather than a vague suggestion to do your exercises. Consistency matters more than intensity here, and most women who stick with a real program notice a meaningful difference within 8 to 12 weeks, not overnight, which is worth knowing going in so you don't quit in week 3, discouraged, assuming none of it is working. For a lot of men watching this, the more common pattern is different, needing to go more frequently, feeling like the bladder never quite finishes emptying, a weaker stream, or getting up multiple times a night, which is very often related to the prostate gradually enlarging with age and putting pressure on the urethra. That's not automatically dangerous on its own, but it's absolutely worth an actual conversation with your doctor rather than a decade of quiet workarounds, because there are real treatments and because occasionally it's a sign of something that does need direct attention. The mechanism itself is fairly straightforward once someone explains it properly, which in my experience almost nobody has done for the men living with it. The prostate sits directly beneath the bladder, wrapped around the urethra. The tube urine passes through on its way out. As it gradually enlarges with age, a change that happens to some degree in the overwhelming majority of men eventually, it physically narrows that tube and puts pressure on the bladder itself, which is why the stream weakens, why starting can take a moment longer than it used to, and why the bladder often signals it's full before it's actually finished emptying properly. None of that is a moral failing or something to quietly manage around for a decade. It's mechanical, it's common, and it has a range of real treatments, from medications that relax the muscle tissue or shrink the tissue itself, to procedures for more significant cases, and the first step for all of it is simply saying the symptom out loud instead of rearranging your day around where the nearest bathroom is. And there's a piece of this that applies to both sexes equally, and it's the one I want to spend the most time on because it's the most fixable and the most commonly ignored. Needing to get up 2, 3, sometimes 4 times a night to urinate. Most people file this under just what happens when you get older and stop thinking about it any further. I want you to think about it differently because of what it's doing to you beyond the disrupted sleep itself. Getting up multiple times a night means getting out of a warm bed, in the dark, often groggy, often without turning on a light because you don't want to fully wake up, and walking to a bathroom on legs and balance systems that are frankly at their least reliable in that exact half-asleep state. I've talked before on this channel about how serious falls can be for people over 60, and nighttime trips to the bathroom are one of the single most common circumstances in which those falls actually happen. The habit of accepting nighttime bathroom trips as unavoidable, rather than treating them as a symptom worth investigating, is quietly connecting two problems that most people never think to connect at all: bladder health and fall risk. There's a real practical reason this happens more at night specifically, beyond simply having had all day to fill up. As we get older, the body's normal rhythm of concentrating urine more at night and less during the day, so you can sleep through it, weakens for a lot of people, and a meaningful share of nighttime trips are correctable once a doctor understands what's driving it in your specific case. Whether that's fluid timing, certain blood pressure medications that increase urine output, undiagnosed sleep apnea, which affects this rhythm in ways most people never expect, or simply an overactive bladder that responds well to specific, standard treatment. The sleep apnea connection specifically surprises almost everyone I explain it to, so let me walk through it briefly. When breathing repeatedly stops and starts during sleep, it changes the pressure inside the chest each time, and the body reads that pressure change as a sign that it's carrying too much fluid. In response, it releases a hormone that specifically tells the kidneys to produce more urine right there in the middle of the night, regardless of how much you drank that evening. Which means someone can be doing everything right, cutting off fluids hours before bed, and still be up 3 times a night because the actual driver was never the glass of water at dinner. It was breathing interruptions nobody had diagnosed yet. This is exactly why I keep steering you toward your doctor rather than toward a home fix, because the right next step depends entirely on which of these is actually happening in your specific body, and that's not something you can reliably sort out on your own from a video, however detailed. I also want to gently push back on a habit I see constantly that feels responsible but often isn't: deliberately holding it for long stretches, either out of a rushed schedule or, honestly, out of the same instinct to just not deal with it. Regularly delaying urination for long periods can weaken bladder muscles further over time and raises the risk of urinary tract infections, the same infections that, as Barbara's story showed you, can masquerade as something far scarier than they actually are. There's a second quiet habit worth naming directly, because almost nobody connects it to any of this: what you're actually drinking in the hours before bed. Caffeine and alcohol are both genuine bladder irritants, meaning they don't just add fluid volume, they directly stimulate the bladder lining in a way that increases urgency independent of how full it actually is. That evening cup of decaf isn't always as decaffeinated as the label implies, and that single glass of wine with dinner does more to nighttime urgency than most people ever suspect. Not because of the alcohol itself keeping you awake, but because of what it's doing to the bladder hours later while you're trying to stay asleep. None of this means giving either up entirely. It means noticing the pattern, the same way I'd ask you to notice anything else we've covered tonight, instead of assuming your bladder simply changed its mind about your habits for no reason at all. One more practical piece before I move on, because it's simple enough to start this week on your own. Bladder training, sometimes called timed voiding. Rather than going the moment you feel the urge, or avoiding the bathroom until you're desperate, you go on a set schedule, say every 2 to 3 hours while awake, whether you feel a strong urge or not, and gradually stretch that interval as your bladder relearns a more normal rhythm. It sounds almost too simple to work, and yet it's a real, evidence-based first step that a lot of urologists recommend before anything more involved, precisely because it costs nothing and helps a meaningful share of the people who actually try it consistently for a few weeks rather than giving up after 2 days. Here's the actual pattern running underneath everything I've described tonight, and it's worth sitting with for a moment. None of this is really about the bladder. It's about a decades-deep habit of treating anything below the waist as a topic too embarrassing to raise, even with your own doctor, even with your own adult children, even with yourself. That habit of silence is the actual thing costing people sleep, costing them fall risk, occasionally costing families a frightening night that a 4-day course of antibiotics could have resolved from the start. If you take one thing from tonight, let it be permission. This is an ordinary, extremely common, thoroughly medical topic, not a source of shame, and your doctor has had this exact conversation more times than you could possibly guess. I think part of why this particular topic stays so quiet is generational, and I say that with real affection, not criticism. A lot of my patients over 60 grew up in households where anything below the waist simply wasn't discussed, not at the dinner table, not with a doctor unless something was visibly wrong, and certainly not with your own adult children, who you spent decades being the strong, capable parent for. Admitting a bathroom habit has changed can feel, to a lot of people I see, like the first real crack in that image, the first evidence that something is different now. I understand exactly where that feeling comes from, and I'm not dismissing it. I still want you to say it out loud anyway, because the silence isn't preserving anything except the problem itself. Which part of tonight actually applied to you or someone you love, honestly? Tell me in the comments, and if you've ever had a Barbara moment, a sudden change that turned out to have a simple explanation nobody thought to check, I'd like to hear it, because I think it helps everyone else watching take a strange symptom a little more seriously instead of a little less. 4 things worth actually carrying out of tonight and into your next appointment. First, say the specific words out loud to your doctor. How often you're going, whether you're waking at night for it, whether there have been any accidents, however minor. Vague embarrassment gets you nowhere. Specific detail gets you an actual answer, and a doctor who's heard this 1,000 times before needs only seconds to start narrowing down what's happening, far faster than most people expect once they finally say it. Second, if you notice sudden confusion, agitation, or a personality change in yourself or someone you love, especially if it came on over a day or two rather than gradually, ask the doctor directly, by name, whether a urinary tract infection has been ruled out before anyone settles on cognitive decline as the explanation. Third, if you're a woman dealing with occasional leaks, ask specifically about pelvic floor physical therapy, not just general exercises you half remember from a magazine. It's a real structured treatment, and it works better than most people expect, usually within a few months of sticking with it properly rather than half-heartedly. Fourth, if you're a man noticing a weaker stream, more frequent urges, or nighttime trips that have crept up gradually, bring up your prostate directly at your next visit rather than quietly working around it for another 5 years, the way so many of my patients tell me they wish they'd done sooner once we finally talk it through. There's a video I've been meaning to make for a while that connects directly to tonight, and I'd rather you hear it from me than stumble onto it separately. The specific way your different medications can end up quietly working against each other, sometimes making exactly the symptoms we covered tonight worse without anyone realizing why. This isn't a diagnosis for your specific symptoms, and it isn't a reason to panic over an ordinary night of poor sleep. If tonight sounded familiar, treat that as your reason to say it out loud at your next appointment. I'm Dr. Walter Hale. Somewhere along the way, we all quietly decided this particular topic wasn't allowed at the dinner table or the doctor's office, and that decision has quietly cost people far more in sleep, in safety, in unnecessary fear, than the mild embarrassment it was ever meant to spare them. Say it out loud, to your doctor, to your family, to yourself. It's just medicine, and it deserves exactly as little shame as anything else on your chart.